Uh, Good afternoon, everyone. I am Dr. Rahul, Assistant Professor from Department of Endocrinology, and I welcome you all for today's clinical case round. For today's CCR, we have very interesting case of a 10-year-old boy, whose management actually exemplify the strong transdisciplinary collaboration that we have here at AIIMS. In this patient, we could not have reached even a diagnosis, let apart the management, until unless we have cooperation of Dr. Deva from Department of Radio Diagnosis, Dr. MC Agarwal, MC Sharma and Dr. Shipragal from Department of Pathology, and Dr. Sameer Bakshi from Department of Medical Law. So to assist us in our presentation, we have today Dr. Mohit, Senior Resident from Department, and Dr. Somya, Senior Resident from Department of Pathology. Not taking much time, I will request Dr. Manish, who is a senior resident in department, begin today's presentation.
Uh, Good afternoon, respected teachers and dear colleagues. I am going to present a case of 10-year-old child presented with history of headache lasting for 30 days and history of vomiting for last 3 days and deviated right eye for 3 days and double vision for 3 days. In particular negative history, there was no history of fever, photophobia, neck sickness, suggestive of meningitis, no history of suggestive of acromegaly, Cushing syndrome, and there was no history of recent weight gain or loss, and there was no history of change in mood. With these complaints, patient was brought to a local hospital at outside institute. In past history, child was apparently healthy and with growth and other developmental parameters, they were normal as in comparison to his peers. In family history, he was a single child. No one in family had other prior cranial surgery, prior cranial intracranial tumor, and neck surgery. In examination, child was hemodynamically stable with height of 157.4 centimeter, height STS of plus 2.42, and weight of 45 kg with weight STS of plus 1.45. Child was pre-pivotal with testicular volume of 1 ml bilateral. And uh, on examination, there was no history suggestive of acromegaly and prolactinoma in the form of galactoria and protein catabolism. In systemic examination, as I have already explained, that there was a history of diplopia and deviated right eye. So in ocular examination, right eye was medially deviated with visual acuity of 6/12 on right side and 6/36 on left side. Extraocular ocular movements, there was a restriction of right eye movement in right lateral gaze. Fundus was normal. In visual field testing, there was suggestion of bitemporal hemianopia. In coming to the investigation, biochemistry was it was they were completely normal. HbTLC was 13.8, TLC was 5300. Coming to the hormone profile, there was clear suggestion of hypocortisolism with serum cortisol of 1.82. However, prolactin was mildly raised 44.63 nanogram per ml, and test was 7 nanogram per deciliter, which was suggestive of pre-pivotal stage. So with these complaints, he was brought to a local hospital where MRI SELA was done, which was suggestive of this is the image of T1 contrast cellular and supracellular mass, which is approximately 4.2 into 3.4 into 2.4 centimeter, encroaching cellular as well as supracellular mass, supracellular location. However, pituitary stalk is not separately visualized, and whole of per se whole of pituitary is also not visualized. Stalk was also not visualized. So with these MRI findings, provisional diagnosis was made of pituitary macroadenoma. So on the basis of this, patient underwent TNTS on 22nd September 2020. Here, in intraoperative finding was suggestive of firm, fibrous, moderately vascular, non-suckable mass. And then, however, whatever decompression was done at the time, that was feasible at surgery. And frozen section, there was suggestion of fibrous tissue and spindle cells were seen. So coming to the histopathology, grayish white to brownish soft tissue mass of 1.5 into 1.1 centimeter with admixture of plasma cells as well as areas of dense fibrosis. And however, there was no well-defined granuloma was seen in histopathology, and admixture of B and T cells were present. So final impression was made of lymphocytic hypophysitis. Then after this, workup for secondary cause of lymphocytic hypophysitis was made in the form of we have done. They were done anti-TPO, serum ANA, AS level, C ANCA, P ANCA. They all were absolutely normal. Beta, however, serum beta HCG was also done at outside institute, which was also normal. In post-operative course, child was absolutely the symptoms of child in the form of headache and vomiting that has resolved. Immediate post-op complication, no CSF rhinuria, no polyuria, and patient was discharged on 20 milligram once a day after breakfast prednisone dose. Patient came to our institute after 1 month of surgery, and where histopathology slide was again reviewed, and there was suggestion of fibrocollagenous tissue infiltrated by dense collection of pure lymphocytes and plasma cells, and no granuloma was seen. Immunostain was negative for CD1A and ascended, and IgG4 positive plasma cells, they were not. Final impression was made of inflammatory etiology. So as there was improvement in immediate post-op period in the form of improvement in squint as well as headache, the plan was to continue with the same dose of prednisolone as child has been already described from outside institute with a dose of 20 milligram once a day. At our institute, biochemistry was suggestive of serum sodium was 150 with other parameters were normal. So corresponding urine osmolality that was 93 milliosmol per kg and serum osmolality of 306. So in view of this, serum urine osmolality was less than 100 and serum osmolality was more than 300 with high sodium was on higher side. So clearly there was suggestion of diabetes insipidus. And prolactin was mildly raised. We have also done prolactin in dilution to see other dilution effect, but that was 46.2. However, free T4 was found to be low, which was normal in surgery period. So on the basis of this, child was started on levothyroxine 50 microgram once a day dose and oral desmopressin 50 microgram once a day. And in subsequent follow-up, the dosage of both these drugs, they were titrated. FDG whole body PET CT was also done for other etiology, but there was no other abnormal FDG avid lesion in other areas of the body. So plan was that child to be followed after 3 months of surgery. So after these slides will be discussed by radiology SR. After 3 months of surgery, we have done MRI Cellular to just see the response of the steroids as well as the anatomically radiological finding of MRI Cellular.
So we have these MR images of this patient. This is the pre-operative scan in which we can see that there is a cellular, paracellular, and a supracellular mass encasing the bilateral carotid arteries, which is also seen on this sagittal scan. And this is the post-operative scan in December 2020. So this is the post-operative area, which the pituitary gland has been removed, and the only stalk part is left. The supracellular part of the tumor is left. At that time, the prednisone was continued at 5 milligram per day because there was decrease in size of this and there was clinical improvement in the patient. So the prednisone was continued and was considered a improving case. So the patient was lost to follow-up due to COVID lockdown, and the patient came back after 9 months of the surgery. And another scan was done in June 2021. So this is the 3-month scan. This is the 9-month scan. In this, we can see that there is slight increase in size of the supracellular component of the tumor. However, because of the clinical improvement, the diagnosis of lymphocytic hypophysitis was continued and the prednisone was increased to 1 milligram per kg per day. So after this, another follow-up scan was done at post-op 12 months period of time, and this was done in September 2021. And in this, we can see there is a definite increase in size of the supracellular mass. So an alternate diagnosis was considered. A tumorous pathology is considered now, and the size has progressed even on prednisolone at 1 milligram per kg per day. So an alternate diagnosis was suggested and histopathology was reviewed. It will be discussed by. So sir, the mass is actually infiltrating in the stalk. In the first pre-operative scan, this is the stalk which is widened by the mass only. So during the operation, the pituitary gland was removed, but stalk is difficult to remove through the transfusion. Yes, sir. So pituitary macroadenoma should not have been the first diagnosis at that time. LH should have been the first diagnosis, and histopathology proved that it was a LH. After the pre-operative scan, in the post-operative scan, we have continued as a diagnosis of LH.
Section examined from the specimen sent to us, and here we can appreciate on the scanner view there are fragments of fibrocollagenous, and here we can appreciate the cellularity, mild to moderate cellularity with interval. showing mild cellularity, and the cellularity is by small round cells. However, these small round cells are forming collections, sort of collections. This high power view, we can appreciate there is a collection which is mixed lymphocytes, plasma cells, which are eccentrically placed nuclei, and few the cells were large in size, having abundant eosinophilic nuclei, uh, philic cytoplasm, and the nuclei is vesicular chromatin. However, the prominent nuclei was not noted, and few of the cells were showing slipper-shaped cells. Uh, so this is a collection of lymphohistiocytes forming a non-necrotizing granuloma. So here again there is a microgranuloma with marked crushing artifact. Again some collection of lymphocytes along with the few slipper-shaped cells. So, the diagnosis was given primarily as lymphocytic hypophysitis, but later on we performed immunohistochemistry, and the cells which were large showed positivity for SAL4, 117, and FLAB. Here we can appreciate this first collection showed positivity for all the three IHCs, suggesting a diagnosis of germinoma, as they are positive for SAL4, FLAB1, and CD11. No other germ cell component or immature cell component was diagnosis was given as germinoma. Thank you.
On the basis of this final diagnosis of germinoma was made, and after that the workup for germinoma was done. So medical oncology consultation was taken at this point of time. First CSF analysis was done, which where we have done beta HCG levels. So they were clearly elevated of 7 milliliters per ml, and alpha fetoprotein they were normal, and LDH was also normal. Management for intracranial germinoma was made in the form of chemotherapy. First, patient was given 4 cycles of BEP regimen, which was cisplatin 60 milligram and bleomycin 25 units, and etoposide 300 milligram. So after that, after 4 cycles of chemotherapy, now child is been planned for whole ventricular EBR. This was a scan of pre-chemotherapy scan, where there was clear suggestion of supracellular mass, which was encroaching up the third ventricle. So after 4 cycles of BEP regimen, size has almost markedly reduced and pituitary is clearly visualized. However, mild residual tissue is present around stalk. So now currently child is doing well, as well as, and now he is planned for radiotherapy cycles. Final diagnosis of intracranial germinoma with secondary granulomatous hypophysitis was made. Coming to the discussion part will be discussed by Dr. Rahul.
Thank you, Dr. Manish, Dr. Mohit, and Dr. Soumya for a well-presented case. So my discussion will be on the lines of the approach that we have taken to reach a diagnosis and an appropriate management in this case. So just to summarize, what we have till here now is a 10-year-old guy who has presented with a cellular supracellular with suggestion of mass effects in the form of diplopia and vision loss, and on biopsy proven to have a hypophysitis, which initially responded at least to a oral course of corticosteroids with a significant resolution on the cellular mass, subsequently only to have again an increase and eventually diagnosed to be having a germ cell tumors. So first I will be discussing regarding the etiology of the pediatric cellular supracellular lesions, followed by how do we distinguish between pituitary adenoma and hypophysitis. Thirdly, varied etiology of hypophysitis. And lastly, briefly about the germ cell tumors, their peculiarities, and briefly the management strategy. So there are a wide varieties of etiology that can present as a cellular supracellular lesion in a pediatric age groups. The most common being craniopharyngiomas, the Rathke's clefts. So if you see here, most of these entity can be distinguished based on the clinical presentation and the imaging modalities that we have today. However, among these, the most challenging is to distinguish a pituitary adenoma from that of an hypophysitis. So even at the baseline, there are certain clinical parameters that can help us suggest that yes, we are not dealing with a pituitary neuroendocrine tumor, but something else. These features are presentation at age less than 18 years. It is relatively uncommon to have a pituitary adenoma at this age group. Second, presence of diabetes insipidus. The presence of a diabetes insipidus is very uncommon in any adenomatous lesion involving the pituitary. And thirdly, the presentation of an hypothalamic dysfunction, which is most commonly early seen in supracellular lesions rather than a cellular lesions. Other than these, there are multiple parameters that can again help us to distinguish between LYH and pituitary adenoma. Again, the presence of diabetes insipidus, a symmetrical gland enlargement, a central stalk position, stalk thickening as it was highlighted earlier, a loss of posterior pituitary signal, intact cellular floor, and a diffuse and homogeneous enhancement of the lesion. However, if you see in this case, there are certain points that goes against the diagnosis of LYH. First is the asymmetrical enlargement, where can be clearly seen here, where on the left side the lesion appears to be much more encasing the IC as compared to that of the left side. And secondly is the post-gadolinium enhancement that we are having here, which is highly heterogeneous and not homogeneous that we are used to typically seeing in a case of LYH. So considering the clinical pictures and the imaging modalities, it would have been very difficult to comment pre-operatively whether it was LYH or a pituitary adenoma, histopathology giving the final answer. So once we have established the diagnosis of hypophysitis, we have to consider the etiologies. The etiologies can be broadly classified into those primary and secondary. Primarily are broadly lymphocytic, granulomatous, and xanthomatous. In secondary, we have a broad variety of etiologies bringing from the neoplasm, from then the cellular disease like RCC, craniopharyngioma, even pituitary adenoma leading to secondary hypophysitis, systemic disease like Wegener's, sarcoidosis, tuberculosis. And lastly, with the upcoming modalities, the immunomodulatory drugs, the CTLA4 blocking antibodies and the PD-1 antibodies. Again, here the important thing to realize is amongst the secondary causes, the neoplasms constitute almost one half of the cases, and even within these neoplasms, germinoma constitute almost 14%. Not only this, the relative contribution of the germinomas towards the hypophysitis in children as compared to adults vary. So here we can see while in the pediatric age groups, the germinomas are constituting almost one-fourth of the cases of secondary hypophysitis. In adults, it's only 14%. Overall, also the neoplasm are much more common in the pediatric age group as compared to the adults. So it's very intriguing to know that how does the germ cells land up being in a position where they are not supposed to be. The answers lies in the embryological development and the migration of the primordial germ cells that begins with the yolk sacs, and eventually these germ cells goes to the genital. However, during this process, a part of them spill over to the midline structures, including the mediastinum and the CNS. And these are the common sites where we commonly encounter the germ cell tumors, the brain, the mediastinums, and the gonads. So these germ cells can go along a line of differentiation. When they have a no tissue differentiation, what we call them as pure germinomas. If there is a component of embryonal differentiation, we call them embryonal cell carcinoma or mature. When there is extra-embryonal differentiation, we call them yolk sac tumors or choriocarcinomas. Again, these is the yolk sac component that produce AFP and the choriocarcinoma that produce the HCG that act as a both diagnostic and a follow-up marker in these individuals. And if there is a composite of these three, then these entities are called as teratocarcinoma or polyembryon. So intracranial germinomas are a very rare tumor. Within the CNS, they primarily occur in the midline region, with majority of these lesions being identified in the pineal area. As a matter of fact, certain institutes have a policy that if there is a lesion in the pineal gland, the first thing they do is a CSF HCG, beta HCG to rule out the germ cell tumors. Again, supracellular involvement by the germ stimule is relatively common, seen in only 10 to 20% of the cases. And the median age at diagnosis is in these individuals is 10 to 14 years, which was similar to our case. Polyuria is the most common presenting symptoms, followed by the headache and visual complaint. Our patient had both. Pituitary stalk thickening is almost seen in 70% of the cases, and the histopathology has been variably reported as lymphocytic or granulomatous on initial evaluation. So there are few peculiarities regarding the germ cell tumors and the beta HCG that I would like to highlight here. So the secretion of HCG from germ cell tumor suggests differentiation towards choriocarcinoma or syncytial blast lineage. Now, CSS level are more sensitive than the serum, and while an elevated level strongly suggests germinoma, normal levels does not rule it out. The reason is twofold. First, we do not have a reference range established for the CSF beta levels, and second is that pure germinoma may be entirely non-secretory. So, in cases where we have a pediatric age group where CSF HCG is detectable, but within the reported range of that particular lab, we are in a gray area as to whether it is a germ cell. In the elevated level, if they are seen pre-treatment, they have a potential role in detecting recurrence in future post-chemotherapy and radiotherapy. The second peculiarity about these germ cell tumor is the intense inflammatory response that they elicit, and they deceive us on two parts. First is this overwhelming immune response can obscure the underlying germ cells, and this was probably the case in our patient, where on the initial evaluation, what we had an intense inflammation only, and only on final looking, we could be able to delineate the microgranulomas and do an IHC for these germ cell tumors. And the second important connotation of these extensive granulomatous inflammation is that these germ cell tumors can initially respond very well to corticosteroids. Again, as was seen in our case, where what we have was that the entire cellular component almost resolved on prednisolone of 20 milligram per kg. However, the supracellular component continues to be there, which eventually progressed on follow-up. So, briefly, the management strategies, it consists of a neoadjuvant chemotherapy with BEP regimen, along with the use of radiotherapy, either in the form of EBRT or the focus to the ventricles. From endocrinological perspective, these patients are followed on the lines of childhood cancer survivors. They are at risk of pituitary dysfunction throughout their life because of LMS, concomitant administration of cranial radiation, and the lesion being diagnosed at a very young age. They can have both pituitary hypofunctioning or hyperfunctioning in the form of central precocious puberty throughout their lifetimes, and they are likely to require a lifelong. So to conclude, in pediatric patients with hypophysitis, germinoma should always be strongly considered and excluded. It can be associated with an intense inflammatory reaction that can result in a diagnostic dilemmas. Early clinical identification is important because these tumors respond very well to chemotherapy and radiotherapy. And lastly, the most important thing is that multimodality treatments involving all the involved discipline is very important to achieve a standard of care that we could in this particular case. Lastly, the acknowledgements to all the faculties in the Department of Radiodiagnosis, Department of Pathology, and Department of Medical Oncology and Nuclear Medicine, without whom this management of this patient would not have been possible. Thank you. Podium is now open to question.
Like very excellent presentation, like
I think,
very,
sir,
very
please.
rare. I've never heard a germinoma from a hypophyseal stalk.
I think, sir, Sabir Bakshi, sir, will be better able to answer this question.
Samir, what are the indications for radiotherapy? Like, is it a multimodal treatment in all patients, or there are specific indications?
So I think if it is a complete excision, then perhaps one can get away with chemotherapy alone. But in my memory, I don't have a patient who had a complete excision and it was kind of R0. So by and large, all the patients that we have seen, we have treated with chemotherapy and radiotherapy.
Because in this like part of the body, it is almost impossible to do a complete excision with a resection-free margin.
That is exactly what I said. So by and large, if there was a situation like that, then one would probably avoid radiotherapy. But seeing the rarity of the tumor and to really have a guideline where it says that no radiotherapy to be done with enough evidence does not exist. So in general, the pattern of treatment is chemo plus radiotherapy.
And chemotherapy is what, 4 cycles?
It's 4 cycles, 3 to 4 cycles of BEP, which is platinum, etoposide, and bleomycin.
and followed by radiotherapy.
Followed by radiotherapy. Yeah.
Thank you.
I think the key learning point here for me and for us from my past experience in intracranial germ cell tumors is to think about them. Be it in neurology setting, be it in endocrinology, be it anywhere. And in my opinion, the easiest test to rule out, although a negative test is not certain, is to do a CSF evaluation of the tumor markers. There have been at least 5 instances that I remember where things have gone on a wrong track and they have actually been picked up on a CSF evaluation of AFP and beta HCG.
No, but for a routine pituitary microadenomas or macroadenoma, CSF evaluation is not done as a part. So what you are talking about is high index of suspicion in patients who do not respond to routine treatment.
So I'm saying a case which has been diagnosed as a certain entity in the brain, you have started treatment, it fails or it goes on a slightly off track. I think there one needs to think, because it's a treatable, it is treatable with drugs. That is, and it's tough to diagnose, it's tough to biopsy. And if you get tumor markers, which you will not get in the blood often in this case. So in such situations, I'm not saying do it in all, but in situations where you have diagnosed and it has gone off track.
So, Samir, my concept is opposite. We get lot of frozen in the neuro, and but they ask you, tell me this is germinoma or not. If it is germinoma, they will not touch. They will just send the biopsy. But you are saying it is for the mixed germ cell tumor. If it is germinoma, give radiotherapy only.
Then
But
it
they
will
are
not
saying,
be picked up.
I'm not saying. What radiotherapists they do, they give radiotherapy only. If it is germinoma, it is a mixed germ cell tumor. Then but you are saying that chemotherapy should be given.
Sir, even in my opinion, even in a germinoma, as far as I know, one would give chemo plus radiotherapy.
Maybe. Why we missed actually, we should have picked in the first. This patient came from outside. And I saw the slides, and I think this is a lot of artifacts, crush artifacts.
Yes.
So we tried our best to prove that this is a pituitary tissue which is crushed, and they're lymphocyte. They've called lymphocytic hypophysitis. So then our next diagnosis was LCH, but the markers were negative. And one day it was presented in your conference, and Shipra showed there is one granuloma. So then we talk about the tuberculosis. At that time, it came in my mind. I have seen cases where the granulomas, it was called granuloma in the neuropathology, and it turned out to be germinoma. So at that time, then we did the markers.
To be honest, sir, this case wouldn't have reached a diagnosis if this microgranuloma wouldn't have been picked.
Actually, Dr. Tandon, every day, whenever he was seeing me, he's after me that give diagnosis. So I started avoiding him. I couldn't give the diagnosis, to be very frank. But when she showed the granuloma one day in the meeting, then I suspected. Then I asked her, I will do the markers, and we did the markers. So actually, now retrospectively, I should have picked in the first time. Although I have not seen the first slide, I have not signed out. But when he told me to review, I should have picked at the first.
We have 1 minute. I'll just share one interesting case in relation to this. We had a case around a 18-year-old young girl from neurology who was being treated with some immune-related disorder of the brain and got multiple doses of pulse prednisolone, this and that. Then I got a consult sitting in my OPD that there is a case of relapsed leukemia in the brain. I just got this consult. So this was a cytopath reported as leukemia lymphoma of the brain, and I got that consult. And when we took the history, there was history of obviously pulse dexamethasone and so on, but there was no history of cytopenias or lymph nodes or liver spleen at any time point, which looked very odd as why it would be there. Then we sent a flow of the CSF, and in the flow sample, no B or T or myeloid cells were picked up. That's when we remember Dr. Rajiv was there. He saw the CSF and he said, "It to me, it is not lymphoma, it is a solid tumor." And that's when the whole thing started, what solid tumor it is. And this girl was actually bed bound. And then we got a a CSF for beta HCG. It was high. We treated with BEP radiotherapy, and this girl is perfectly fine now, perfectly fine, who was actually bed bound. So I think it's worth thinking about.
Exactly, sir. Wherever we are even having a low index of suspicion, before going for surgery, it's better to go with the CSF analysis to look for HCG, at least to rule out that yes, it's not germinoma, where the treatment is entirely different, unlike other cellular supracellular lesion, where chemotherapy and radiotherapy forms the mainstay. Thank you everyone for your valuable comments.
Very good afternoon. On behalf of Surgery Unit 4, I'd like to thank all of you for coming to the CCR. The topic for today's CCR is 2 in 1. It's actually a story of how life always finds a way. There were a lot of obstacles, a lot of problems, but we were able to overcome that with good team effort and methodological planning and one sleepless night. And we were able to achieve something which was first of its kind in the institute. The case will be presented by Dr. Kritika, who is a junior resident in Department of Surgery, and she'll be assisted by Dr. Srinivas, who is from Pediatric Nephrology, and the review of literature will be presented by Dr. Adarsh. I'll hand over the mic to Dr. Kritika, please.
Thank you, sir. Good afternoon, everyone. So, this is the story of two children at All India Institute of Medical Sciences, where one child gave a gift of life to another child. The donor here was a 7-year-old female child who gave both of her kidneys to a 12-year boy. So, let me begin with the donor profile. The 7-year-old female child unfortunately sustained a gunshot injury on 27th of April 2022. The child was initially taken to Postgraduate Institute of Child Health at Noida in an unconscious state, where primary care was given, and further, the child was referred to Trauma Center at AIIMS on that same night. So at AIIMS, on the initial examination, in view of threatened airway, the child was intubated, and further, she was put on mechanical ventilatory support. However, her hemodynamic parameters were normal, with the pulse rate of 60 beats per minute, and her blood pressure was 148 by 86 millimeters mercury. Further, on neurological examination, her Glasgow Coma Scale score was even B1 M3 on presentation. Both of her pupils were bilaterally dilated and non-reactive. Pelvic compression test was done and chest compression test was done, which was normal. And also log roll examination was done, which was normal. On clinical examination, there was no evidence of any long bone fracture. However, there was a sutured lacerated wound which was around 2 cross 1 centimeter behind her left ear. Further, the imaging revealed there was a comminuted open fracture with fragments of foreign body in her left temporoparietal junction. Also, there was a retained foreign body in her right parietal region, which probably was a bullet. Also, there was cerebral edema with a mass effect with uncal and tonsillar herniation with a partial effacement of the basal systems. Further, protocol-guided resuscitation was carried out with supplementation of IV fluids, tetanus prophylaxis, IV antibiotics, IV analgesics, and also anti-epileptics. And the wound was thoroughly lavaged and it was resutured. Initially, the plan was to do an emergency decompression craniotomy. Sadly, the child further deteriorated just within a couple of hours to even VT M1 with absent brainstem reflexes. Also, her bilateral pupils were dilated and fixed. In view of absent brainstem reflexes, the family was counseled. The family was explained the poor prognosis of the condition, and further they were counseled for organ donation by the team of neurosurgery and also the team of Orbo at AIIMS. After obtaining the consent from the family members, the first apnea test was done, which was positive at 9:11 p.m. So after more than 6 hours of the first apnea test, the second apnea test was conducted, which was also positive. The child was further declared brain dead at 11:40 a.m. The cause of death here was refractory raised intracranial pressure with severe head injury with diffuse cerebral edema, all of which following a penetrative gunshot injury. Once the legal formalities were ensured, the decision was taken to proceed with the multi-organ harvesting. Unfortunately, there was no recipient under similar age category for heart transplantation. Therefore, heart could not be retrieved. However, heart valves were retrieved from the team of CTBS AIIMS New Delhi. Liver was retrieved from the team of Apollo New Delhi, and bilateral kidneys were retrieved by Department of Surgical Disciplines from our own institute. And bilateral corneas were retrieved as well. So once the decision was made to proceed with the multi-organ harvesting, there were multiple challenges at every stage. The journey was not at all a smooth journey. The donor was a 7-year-old female child with a small body habitus with a weight of just 30 kgs. So the kidneys were obviously small with less functioning nephrons, also with very small caliber of blood vessels. So our primary concern was how to make the best use of these two kidneys. So the options whatever we had at that time were we could either transplant individual kidney into separate adults, but the problem was there would be discrepancy in size mismatch and also the risk of hyperfiltration injury was high. So the other option was we could implant the en bloc kidneys in a single adult, but still the mismatch risk would persist as the donor was young and small. The other option was implant individual kidneys in an age-matched pediatric recipient. But still, the risk of vascular thrombosis due to narrow caliber of donor and recipient vessels was persisting, so the risk of vascular thrombosis was still high. So the only option, the best option what we were left with was to implant bilateral kidneys en bloc in a pediatric recipient. So further, we proceeded with the multi-organ retrieval on 29th of April 2022. Here, midline incision was given, which extended from suprasternal notch to pubic symphysis. Once the liver was harvested, the kidneys, both of the kidneys were removed en bloc with the sufficient length of aorta and the IVC. As we see here, both of the kidneys were retrieved en bloc with the sufficient length of aorta, sufficient length of IVC. Bilateral kidneys were perfused with the custodial solution, and also on bench while dissecting it was noted that the left renal vein, as we can see here, was detached from the IVC. So however, the decision was made to anastomose the left renal vein and the IVC separately in the recipient at a later stage. And also the proximal ends of the aorta and the IVC were closed using 6-O-proline suture. And both of the kidneys were freed from the perinephric tissue and also the adrenal glands. So this is the picture of the kidneys after dissecting on the bench. So this is the final picture after the dissection. So here we can see bilateral kidneys and the bilateral ureters. So this is the aorta, this is the IVC, and this is the detached left renal vein. So these are the bilateral kidneys which are dissected free of the perinephric tissue. So now I would call upon Dr. Srinivas from Department of Pediatric Nephrology to brief you with the details of recipient.
Good afternoon all. Once we got a call from the pediatric, from the Orbo and the transplant surgery team, we started calling up the patients who had matched blood group, and among which we were able to call around 4 recipients, and among which one of the child was the patient we will be discussing now. So he's Master D. He was a 12-year-old boy who had been managed by us with chronic kidney disease. Presented to us initially in September 2018. Presented to us with polyuria, polydipsia, and failure to gain height since 5 years of age. And along with that, he had bony abnormalities in both the knees for the past 3 years. In the family history, he was an adopted child, and in the context of the transplant, as he had blood group ABO incompatibility, the parents were not able to be the potential donors. So on evaluation further, he was diagnosed as nephronophthisis and also had complications in terms of anemia of chronic disease and mineral bone disease, for which he was managed with medical supportive therapy. And once his creatinine gradually, his GFR dropped gradually, then he was started on chronic ambulatory peritoneal dialysis, and he was followed up further. However, there was poor follow-up, and he had persistent hyperphosphatemia, and even after medical management, he had hyperparathyroidism. Hence, underwent a parathyroidectomy surgery in Jan 2020. So he was called up, and initial clinical examination was performed. He was clearly having short stature, and otherwise his vitals were normal, except his blood pressures were around stage 1 hypertension on antihypertensive drugs. Other than that, he had features of rickets, and he also had pallor. Our system examination were within normal limits. So, in the context of transplant from the nephrologist perspective, what were the we had some challenges in terms of short stature, so that there will be little space for the surgeons to place the kidneys, and he was on manual peritoneal dialysis for almost 3 years. So he had other features in terms of hyperparathyroidism and persistent hyperphosphatemia due to less adequate dialysis being performed by the parents, and post parathyroidectomy status, which is known to have aggravation of the hypocalcemia, and as there was a cadaveric transplant, which by itself is a high risk transplant. So, in the pre-transplant preparation, clinical assessment was performed for his wellness prior to surgery. Parents are counseled regarding the high-risk status for the transplant, and the consent was taken. Baseline investigations were performed to look for any metabolic abnormalities, and viral markers were done to screen for any occult viral infection. As he was on peritoneal dialysis, his peritoneal dialysis fluid was drained, and the cytologies were performed, which was normal, and donor was also assessed for other compatible parameters. CDC cross matching was also performed, which was negative in this child. So for this, as it is a high risk transplant, we planned induction immunosuppression with ATG, and he received almost 4 doses with a cumulative dose of 6 milligram per kg, and initially was started with methylprednisolone and post-op day on the same day, and was followed by tapering of the steroids. On maintenance immunosuppression, he was started on tacrolimus on post-op day 1, and doses were titrated as per the trough levels, and mycophenolate mofetil was also started and gradually was increased to 1 gram per day.
Thank you, sir. So coming to surgical challenges in the recipient, not only technical factors, there were also physiological factors which were challenged. So coming to technical challenges, since the child was of 126 centimeter height and also just 35 kgs in weight, this operative field was obviously small. And also there was a CAPD catheter in close proximity to the operative field. So we planned to extend our incision longitudinally from subcostal region till the pubic symphysis, and also to place it laterally just to avoid the CAPD catheter. And also, since we had to implant both of the kidneys in such a limited space, we faced a dilemma to perform a native nephrectomy or not. And coming to the anastomosis, there were multiple anastomosis, vascular and ureter. So coming to vascular anastomosis, we had options for arterial anastomosis, whether to perform it with the aorta, with the common iliac artery, or with the external iliac artery. And also coming to the venous anastomosis, we had options between performing anastomosis with the IVC or the external iliac vein. Coming to the ureter, we had 2 ureters here. So we had multiple options. We could either do 2 separate anastomosis, or we could anastomose our donor ureter with the recipient native ureter, or even we could form a common conduit with the donor ureter and perform the anastomosis with the bladder. Coming to the physiological challenge, here in the recipient, we were expected to clamp the 2 major vessels of the body, that is IVC and the aorta. So there is chance of hemodynamic instability at the time of clamping, which was around 20 to 30 minutes. And also, just after the declamping, since the significant circulatory volume will be directed towards the transplanted kidney, there is a chance of hypovolemia, and also hemodynamic instability just after declamping. Here came the role of our team from anesthesia to maintain the fine balance between maintaining the adequate circulatory volume status at the same time not to overload the child with the fluid. So our final plan was to perform en-bloc renal transplant with the bilateral kidneys with the modified Gibson's incision extending it longitudinally and laterally, and also to place the kidneys extraperitoneally and to perform venous anastomosis with the IVC and the arterial anastomosis with the right common iliac artery, and coming to the ureter to perform two separate anastomoses. The child underwent en-bloc cadaveric renal transplantation on 29th of April 2022. So here as we can see the IVC of the donor, this is the IVC of the donor and this is the detached left renal vein of the donor. So both of them were anastomosed to the IVC of the recipient. And also donor aorta was anastomosed end to side with the right common iliac artery of the recipient in a continuous manner. So the clamp on and off time was about 35 minutes, and once the clamps were off, the kidneys were noted to be pink and also turgid with the brisk immediate urine output. And further, two separate modified Lee Grigor extravesical neocystoureterostomies were done with 5 OPDs over separate DJ stents, and hemostasis was ensured and a perigraph drain was plased. So these are the final intraoperative pictures. Here we can see two bilateral kidneys. This is the right kidney which is placed inferiorly and slightly laterally, and this is the left kidney which is placed superiorly and slightly medially. And these are the two separate ureters, and it was ensured there was no kink or torsion between the ureters. And the kidneys, we can notice here, both of them were pink and turgid after declamping. And this is the picture which shows the common iliac artery which was anastomosed with the donor aorta. Coming to the post-operative course, the child was hemodynamically stable with the immediate urine output of 200 ml in the first hour. The child made an uneventful recovery in the post-operative period with the decreasing creatinine value of 0.8 on post-op day 3. And the DJ stents and the CIPD catheter were removed on post-op day 7, and the child was discharged on post-op day 8 in stable condition with the creatinine of 0.5. According to the protocol, the DTPS scan was done on post-op day 5, which showed bilateral both of the kidneys with adequate perfusion and also with non-obstructive clearance. Now I would like to invite Dr. Adarsh to brief you with the details of review of literature.
Thank you, Dr. Kritika. Good afternoon, everyone. So, chronic kidney disease is emerging public health problem across the globe, with a global prevalence of around 13.4%, and the number of patients with end-stage renal disease which are on hemodialysis around 5 to 7 millions, and the number of patients we are losing because of CKD is around 14 lakhs per year. And across the globe, the total number of renal transplant annually were done around 81,000. In India, the prevalence of chronic kidney disease is slightly higher than across the globe, and the number of patients with end-stage renal disease in India is around 1,74,000. The number of deaths because of CKD is around 2.3 lakhs, and number of renal transplant we are conducting around 10,000. In case of chronic kidney disease, renal replacement therapy can be done in the form of dialysis and in the form of transplant. The transplant gives much more survival rate in comparison to the patient on hemodialysis. The 5-year survival rate of renal transplant patient is around 94 to 97%. In this bar diagram, you can see the number of patients who receive the transplant. They have overall survival is much more than the patient who are on hemodialysis. Renal transplant is not only improve the overall survival, but it also improve the skeletal growth, appetite, and the nutrition of patient, cognitive performance, psychological development, and it overall increase the quality of life of patient. So now we come to the donors. Donors can be living or it can be deceased. In India, majority of the donors are living, and deceased donor can be donor after cardiac death, and donor after brainstem death. If we see the overall organ transplantation in India in 2019, total of 12,666 transplants were done, out of which majority around 84 were living organ transplantation, and disease were around 16%, which leads to the around disease donor rate of 0.5 per million population, which is very lower in comparison to the other countries. India is like very less organ donation rate. So government of India has taken various steps to increase the disease donor rate, which comprises the promotion of organ donation after brain death, implementation of extended criteria, which includes the brain dead donors aged more than 60 years, a donor of 50 to 59 years of age, with two of the following features: maybe hypertension, creatinine more than 1.5 milligram per deciliter, or cerebrovascular cause of death, ABU incompatible renal transplant, and the organ share. And now there is a newer concept of domino kidney transplantation, where the paired kidney donation for incompatible donors and recipients. So pediatric disease donor itself is a unique challenge for all of us, where the weight of donor is less than 20 kg. It has a small nephron mass. It has small blood vessels, which expose the higher risk of vascular and neurological complication. And there is always a challenge whether to implant in block kidney transplant or a single kidney. So pediatric kidney allograft, it was started in 1972, where it was done in adult using an in-block kidney transplant technique. In 1990, there was single pediatric kidney transplant was done in adult. So there are different thoughts, school of thoughts, whether to implant a single kidney or a in-block kidney. In implantation of a single kidney, it benefit two recipients, and it also technical easier in comparison to the en block. But single kidney at the cost of, if we implant a single kidney, it has high risk of vascular thrombosis and the graft failure. En bloc kidney transplantation, in which we harvest both the kidneys along with the major blood vessels, IVC and aorta. We anastomose allograft vena cava and aorta to the recipient vessels. It expands the donor pool. It increases the overall nephron mass in the recipient. It decreases the chances of hyperfiltration injury in adult recipients. It reduces the difficulty of vascular anastomosis. It causes only lesser amount of pediatric transplant, around 1.7%. So there is study, comparative study, which compared 66 of en bloc renal transplant from pediatric donor and 434 adult kidney transplant. There was no significant difference in the 5-year survival of the graft. So another multi-center study, which was conducted by United Network of Organ Sharing Data, which concluded that en bloc kidneys have a better survival than a single kidney from donor 0 to 5 years. Progressive increase in the donor weight was associated with the improved graft survival, and 5-year survival of en bloc graft was better when compared with the single graft, and graft thrombosis was significantly less in en bloc renal transplant when the donor body weight was more than 50 kg because of good caliber of blood vessel. So at the end of the day, our pediatric disease donor is an acceptable option, and en bloc transplantation is also feasible option. It results in the similar outcome if you compare to the single adult kidney transplant, and the most important, it increased the overall donor pool, which is the need of hour at the current scenario.
Thank you, Adarsh. See, to provide quality care, improved outcomes, what is needed is an excellent teamwork, and deceased donor program is no exception. There are many spokes in the wheel of well-oiled deceased donor program. The first and the most important is the family. The family is not only expected to cope with the untimely tragedy. See, most of the donors are very young patients. So the families will have an enormous heartache, and they not only have to face this tragedy, they need to face the counseling which we provide to them. So there comes the importance of the counselors. And once a call of the deceased donor comes, you won't believe that dozens of staff and faculty members are put into motion, and most of the staff has to spend hours not sleeping or traveling hundreds of kilometers just to make one successful deceased donor program. And first, I request Dr. Arvind Bagga to give comments about what they face when they have a call for deceased donor program, followed by comments from Professor Deepak Gupta and Dr. Aarti Vij, who combinedly have changed the face of the deceased donor program post-COVID. Like, we are very happy that it is almost to the pre-COVID level or probably better than that. First, Dr. Arvind Bagga, please.
Fewer ठीक है आवाज आ रही है? Pediatrics, we would be doing far fewer even cadaveric transplants compared to adults. But the things that are really set in motion, suppose we do get a call, the first thing is that we try to define that how many patients would qualify based on the blood group. So that's our really first step. And fortunately, our list is not too long. It's a small list. I would imagine less than 15 children, perhaps. So you are able to figure out, 3, 4 जो बच्चे हैं who are belonging to the same group, and we would call all of them, because at times some of them are not able to travel so far. किसको आता है, किसी को बुखार है, and so on. So you would end up getting about 4 children or 3 children typically, and once they come, they are assessed, and then you would send you would talk to the surgeon and say these are the kids we have. We would normally tend to follow the protocol of their being listed, the time in which they have been listed. But given the small numbers, you've got 3 children who are A positive. There also are issues which is kind of better. The surgeon, Dr. Bansal, mane ya nahi mane, ye bacha bahut chota hai ya bahut bada hai, or somebody else. So we take a call based on that. So it's out of those 3, 4 children, our immunosuppression is clearly different when we are doing cadaver transplants, because our standard immunosuppression is using IL-2 receptor blockers and triple immunosuppression. Here we would be using ATG, and as was done here as well. Overall, I would imagine that our cadaveric transplants have done well. I think with the rapidity with which they are handled, good surgical expertise, that's obviously very strong here. So our cadaveric transplants, they have done well. The kidneys show good function. But I can't even remember one cadaver that's failed. Perhaps only one, that's probably never worked. But our cadavers, touch wood, do better than our live related at times. So I think because the level of heightened responsibility, etc., is far more with cadavers. I was just talking to Dr. Aarti. This is perhaps the second child that we are following who has got 2 kidneys inside. The first was a child who was operated in Apollo Hospital and who was following up. That was not an en bloc. That were 2 separate kidneys. There were 2 separate kidneys. I think Dr. Bansal knows that. Yeah, yeah. But that child has done well. He's now almost 15 years post. 11 years, and he is still running below a creatinine of 1. So you can well imagine, 11 years post transplant, still with a below a creatinine of 1. He has got other problems, deafness, etc., and some kind of immunodeficiency. But overall, he has done well, and I'm sure, even this child would. Thank you very much, Dr. Bansal and team, for the support, in getting these things. Yeah. And I think our criteria, for en bloc would really be children who are below 10 years. If your donor is below 10 years, probably, en bloc is a good idea. Below 5, I think बहुत कम. I can't even remember even one child जहाँ पे हमने below 5 किया है. But I think 5 to 10 years, en bloc is perhaps the best place.
out and that fellow was working in ILBS. So he took the donor back to ILBS. So they harvested the kidneys and did it in
Okay. First, take this question forward because sometimes we've had very young donors, even 3 or 4 years at AIIMS as well. हाँ जी लेना ही पड़ेगा. तो मेरे को ये बताइए कि what is the age that you will accept for kidney transplant? 1 year onwards? If there is a brain dead,
There's some below 5, but I would if you take a end block, take the end block.
we should know that even if we have a 1 year old, this
reported 9 months.
yeah.
as the young-
Yes.
That can be done.
That can be done. Okay. Then we have to yeah.
Teaching is not bad, really. Yeah.
How many anesthetists do we have here? Anyway, just for the information, I think this is the only condition, the organ harvesting so-called, wherein the anesthetist can actually leave before the surgeon, You put on the clamp, switch off the monitor, and the surgeon keeps on doing the closure. Sorry, sir? No. Anyhow. So this was actually a very challenging case for us because she had gunshot injury, medico-legal case, and a very young child wherein many people in our team were not very sure whether the pediatrics organs can be taken and then who will be the kind of takers for these organs. But then we have actually revamped the entire program at our center in collaboration with the Orbo. And what you see on the right side of this girl child is a small banana tree, stem of a tree. I'd actually on the previous slide it was shown that I had given a call for people to light some candle or implant some tree. So one faculty from Italy actually she has planted this banana tree and you see the inscription ROLLY. So that tree is dedicated to them. This is the amount of dedication and respect people do across the world. And now I was sent this picture. The leaves have started coming out in this banana tree. And this girl is very special because it reminds me of a similar incident which happened way back in 1994. You've seen a movie called The Gifted by the Nicholas Green, The Gifted Hands. That in that case, one child, I think 7 years of age, was shot dead. He was the son of a BBC reporter. Father is still alive, Reginald Green. And at that time, the donation rates were dismally low in Italy as compared to as what we have in our country. So they did a very massive organ donation and awareness program in that country. And now they are kind of in the top 10 countries leading the donation program. So we are also using this case of this girl child and promoting it big time. Apart from public awareness, which we have been talking about, I'm not sure if probably ma'am will also agree with me. We have been talking about organ donation since 1994 when the THOA Act came. But if you look at the statistics across the country, our numbers have remained exactly constant. We have never crossed this magic figure of 1000. So many centers, you talk about Gujarat, Surat, Tamil Nadu model, Kerala model, and PGI, Chandigarh, and some other parts. We are just around 700, somewhere like that. So probably we need to re-strategize where actually we are going wrong. And what I have understood in the last 2 decades of my practice at AIIMS is that it is the lack of awareness amongst the clinician, the lack of initiative by the clinician. I'll give you a very simple example. Most of the neurosurgeon, fortunately or unfortunately, they think if they declare more, the general feeling will be that this person is killing more. He is not an apt neurosurgeon. While the actual truth is that these are the patients who are non-salvageable patients. All these patients who are coming for donation, they are the M1 patients, non-salvageable, non-operable patients. In our country, we get almost 150,000 deaths every year from traumatic brain injury. 1.5 lakh लोगों की मृत्यु होती है head injury से. Out of that, we are just converting 700 because people are not certifying. Now we are certifying all deaths, brain death certification. And the other thing is that we had a lot of refusals. I mean, our conversion rate from certification to acceptance was less than 10%, the consent taking process. So we had, ma'am, almost like less than 5 to 7 donations per year. Yeah. So yeah. So anyhow, but we are trying to promote it, and then we are taking personal interest. Like we are sitting for each and every counseling and consent from the patients, and we are getting the results. So to the surgical disciplines, the only thing we can say is, please be ready with your patients, and we'll give you at the right times the right patients. Thank you.
Can I take this 2 minutes opportunity? Everybody's here. I had some technical things. I agree with what Dr. Deepak is saying, and he's really taking a lot of initiative. And I just hope that he can, enthuse his department and the other treating physicians so that it becomes a culture. It always happens in AIIMS. One faculty will take proactive interest, and we see a jump in donations. Like I can tell you, when Dr. Mishra was the chief of trauma center, that was a period when we saw a lot of donations. And now, thanks to Dr. Deepak, he's taking a lot of initiative. And again, it's the treating physician who has to identify the donors. So please take that initiative on and convince more treating faculty. Now, in the last few donations, there were some coordination issues which I want to confirm. One was that Noto was repeatedly saying about the uploading of the list. That is sorted now between nephrology department and APKE. There's a common list, or now what? How are you doing it? वो तो common ही होगा नेफ. No, list is same. It's common, but so all right. I mean, in the first, वो नहीं हो पाएगा, वो नहीं हो पाए. That can no, and that will not happen now. So I've discussed that. अच्छा ठीक.